2017 European Society of Cardiology in management in patients with ST elevation myocardial infarction. Worldwide, ischemic heart disease is the single most common cause of death and its frequency is increasing. However, in Europe, there has been an overall trend for a reduction in the ischemic heart disease mortality over the past 3 decades. Ischemic heart disease now accounts for almost 1.8 million annual deaths, or 20% of all deaths in Europe, also with large variation between countries. This is statistics from our CCU in Al Jahra Hospital. As you notice, acute coronary syndrome accounts around 60% from our admission to CCU. Among acute coronary syndrome patients, ST elevation MI account 22%, which is a considerable population. So the definition of acute myocardial infarction regarding the last guidelines, the term acute myocardial infarction should be used when there is evidence of myocardial injury, defined as an elevation of cardiac troponin values with at least one value above the 99th percentile upper reference limit, with necrosis in a clinical setting consistent with myocardial ischemia. Factors that affect the mortality of ST elevation MI: advanced age, clinical classification, time delay to treatment, presence of emergency medical system-based STEMI networks, treatment strategy, history of MI, diabetes mellitus, renal failure, number of these coronary arteries, left ventricular ejection fraction. I will focus on time delay to treatment. Time delay to treatment, either patient delay or emergency medical system delay or system delay. Patient delay starting from onset of chest pain until first medical contact, either in PCI capable center or non-PCI capable center, or just calling the ambulance. Emergency medical system delay starting from receiving the call from the patient until first medical contact in the ambulance. To minimize this delay, awareness of the patient about symptoms and signs of myocardial infarction is very important. So, after first medical contact, we will start the system delay. To minimize the system delay, you have less than 10 minutes to diagnose ST elevation MI. After diagnosis of ST elevation MI, if your patient landed in PCI capable center, you have just 16 minutes from diagnosis till reperfusion by wire crossing. If you are in non-PCI capable center or are in the ambulance, if you have 120 minutes, if you have less than 120 minutes from diagnosis till reperfusion by wire crossing, so you should go directly to the PCI capable center and take care you have less than 90 minutes from diagnosis till the reperfusion by wire crossing. If you have more than 120 minutes till reperfusion by wire crossing, so you will go directly for lytic therapy, and you have less than 10 minutes for lytic therapy. This is the strategy clock. As you see here, from the diagnosis of ST elevation MI, if you have more than 120 minutes, you should go directly for lytic therapy. You have 10 minutes to lyse the patient. After lyse the patient, immediately you should transfer the patient to the PCI capable center, and you will re-evaluate the patient after 60 to 90 minutes for signs of successful reperfusion. If your patient successfully reperfused, so you should do a routine PCI between 2 to 48 hours. If your patient failed to reperfused by lytic therapy, so you should go directly as a rescue PCI immediately. These also stages or phase of ST elevation MI. Early phase starting from 0 to 12 hours. Then from 12 hours to 48 hours, you have evolved ST elevation MI phase. After 48 hours, this is the recent STEMI. As you see here, in the first 12 hours, you have the two options, either lytic therapy or primary PCI, but primary PCI always preferable than lytic therapy. After 12 hours, you didn't have the option of lytic therapy. The only option is primary PCI. But if your patient is symptomatic, so the recommendation for primary PCI is class 1, level of evidence C. If your patient is asymptomatic, your recommendation is class 2A, level of evidence B. But after 48 hours, if your patient is asymptomatic, and this is a new recommendation, it is class 3 to do primary PCI for the patient. Relief of hypoxemia and symptoms. Oxygen is indicated in patients with hypoxemia. Arterial oxygen is less than 90%, or oxygen partial pressure less than 60 millimeter mercury. This is the class 1 level of evidence C. But what is new? Routine oxygen is not recommended in patients with oxygen saturation more than 90%. This is harm, and this is based on avoid trial. For symptoms, titrated IV opioid should be considered to relieve pain, class 2A level of evidence C. A mild tranquilizer, usually benzodiazepine, should be considered in very anxious patients. Procedural aspect of the primary PCI. For infarct-related artery strategy, primary PCI of the infarct-related artery sure is indicated class 1 level of evidence A. New coronary angiography with PCI, if indicated, is recommended in patients with symptoms or signs of recurrent or remaining ischemia after primary PCI, class 1 level of evidence C. Infarct-related artery technique, stenting is recommended over balloon angioplasty. This is in primary PCI, class 1 level of A. Stenting with new generation drug-eluting stent is recommended over perimetal stent for primary PCI, class 1, also level of evidence A. Radial access is recommended over femoral access, class 1 level of evidence A. Routine use of thrombus aspiration, this is also a change in the guidelines. Routine use of thrombus aspiration is not recommended, class 3 level of evidence A. Routine use of divert stenting is not recommended, class 3 level of evidence B. Non-infarct artery strategy. Routine revascularization of non-infarct-related artery lesion should be considered in STEMI patient with multi-vessel disease before hospital discharge. This is also a new recommendation, class 2A. Non-infarct-related artery PCI during the index procedure should be considered in patient with cardiogenic shock, class 2A level of evidence C. CABG should be considered in patient with ongoing ischemia and large area of jeopardized myocardium if PCI of the infarct-related artery cannot be performed. For lytic therapy, the recommendation, when lytic therapy is a reperfusion strategy, it is recommended to initiate this treatment as soon as possible. You have just less than 10 minutes. Class 1 level evidence A, fibrin-specific agent tenecteplase, alteplase, retiplase is recommended. Class 1 level evidence B, high dose of tenecteplase should be considered in patients more than 75 years old, which is a new recommendation. Half dose of lytic therapy for patient aged 75 equal or more than 75. This is a new recommendation. Half dose, not inferior to the full dose, but you will save the bleeding risk for this patient. Antiplatelet co-therapy with fibrinolysis, oral or IV aspirin is indicated. Clopidogrel is indicated in addition to aspirin. Dual antiplatelet for up to 1 year in patient undergoing fibrinolysis and subsequent PCI. For anticoagulation, enoxaparin IV followed by subcutaneous unfractionated heparin given as a weighted adjusted dose bolus followed by infusion in patient treated with streptokinase, fondaparinux IV bolus followed by subcutaneous dose 20 hours later. Transfer after fibrinolysis. Class 1 level of evidence need. Just after the patient receiving lytic therapy, you should transfer the patient immediately to the PCI capable center. intervention following fibrinolysis, emergency angioplasty and PCI is recommended in patients with heart failure, shock. Rescue PCI is indicated immediately when fibrinolysis is filled less than 50% resolution of ST segment elevation. Angiography and PCI of the infarct-related artery, if indicated, is recommended between 2 and 24 hours after successful fibrinolysis. Emergency angiography and PCI needed is indicated in the case of recurrent ischemia or evidence of re-occlusion after initial successful fibrinolysis. Very important logistic issue for hospital stay. It is indicated that all hospitals participating in the care of ST elevation MI patients should have CCU or ICU transfer back to a referring non-PCI hospital. Now, you lyse your patient, transfer immediately to the PCI capable center. Then now the time for transfer the patient back to the non-PCI hospital. Same day transfer should be considered appropriate in selected patient after successful primary PCI, those without ongoing myocardial ischemia, arrhythmia, hemodynamic instability, not requiring vasoactive or mechanical support, and not needing further L revascularization. You can transfer the patient the same day of primary PCI or PCI. Monitoring, it is indicated that all STEMI patients have ECG monitoring for a minimum of 24 hours. Length stay in CCU. It is indicated that patients with successful reperfusion therapy and an uncomplicated clinical course are kept in CCU or ICU for a minimum 24 hours. Whenever possible, after they may move to step-down monitor the bed an additional 24 to 48 hours. So you should monitoring your patient 24 hours in CCU, then transfer the patient to the monitored general ward or step down for more 24 hours or 48 hours. Your patient just need monitoring 72 hours, no more. Hospital discharge, early discharge within 48 to 72 hours should be considered appropriate in selected low-risk patients if early rehabilitation and adequate follow-up are arranged. MENOCA. MENOCA, it is a new term released by the recent guideline. MENOCA is a myocardial infarction with non-obstructive coronary arteries. What is MENOCA? The diagnosis of MENOCA is made immediately upon coronary angiography in patient presenting with feature consistent with an acute MI as detailed by the following criteria. Number one, your patient should have universally MI criteria. This is a true patient of ST elevation MI at presentation. Your patient should have non-obstructive coronary arteries on angiography defined as no coronary arteries more than or equal 50% in any potential infarct-related artery. Number three, no clinically overt specific cause of the acute presentation. So we will diagnose MENOCA after diagnose ST elevation MI after coronary angiography. And also, this algorithm showed you how to diagnose MENOCA. First, you have a patient presented with or landed with ST elevation MI. You will deal with the patient as a routine. After coronary angiography, if the patient have less than 50% occlusion of the infarct-related artery or the coronary arteries, so now you will diagnose the patient as a MENOCA. But what is the suspected diagnosis of MENOCA? What is the differential diagnosis of MENOCA? The differential diagnosis of MENOCA, either myocarditis and should be confirmed by transthoracic echo or by cardiac MRI or even by endomyocardial biopsy, or your patient had coronary disease epicardial level or microvasculature level, like your patient may have dissection, spasm, or embolic, or your patient may have an ulcerative or fissuring atheromatous but less than 50% occlusion of the artery. Another diagnosis, Takotsubo. Another one, pulmonary embolism, which can be confirmed by the CT pulmonary angiography. Pulmonary embolism maybe give some change, especially in the inferior leads. Or your patient have a secondary MI or what's called oxygen supply demand mismatch. To summarize, this showed you what is the change in the new guidelines since 2012 until 2017. For radial access, it changed from class 2A to class 1A. Drug-eluting stent over perimetal stent from class 2A to class 1. Complete revascularization from class 3 to class 2A. Thrombus aspiration from class 2A to class 3. No more thrombus aspiration. Bivalirudin, it changed from class 1 to class 2A. Enoxaparin, it changed from class 2B to class 2A. Early hospital discharge, changed from class 2B to class 2A. Oxygen supply from oxygen saturation less than 95 to oxygen saturation less than 90. And what is new, to use oxygen in patient with arterial oxygen saturation 90% or more, it is a harm, class 3. New recommendation for age 75 or more, half-dose lytic therapy. Combination therapy, as Dr. Peter mentioned, combination therapy by ezetimibe or PCSK9, now it is class 2A. Class 2B, switching from one P2Y12 antiplatelet to more potent, clopidogrel to ticagrelol, after 48 hours from the lytic therapy to minimize the bleeding risk. And at the end, routine use of default stenting is class 3. Thank you.
Thank you so much, Dr.